Okay. What I'm going to be teaching today is pain and anesthesia. So starting with pain, it's a little diagram here. Don't worry too much about it. It's basically showing you that pain is multifactorial, right? Not only is it whatever pain you're experiencing, it's your kind of attitudes towards it, your psychological distress that comes with it, and kind of any comorbidities that are maybe causing it or influencing it. But it's basically influenced by a load of things rather than just the pain itself. But to focus on pain itself, there's basically two main types of pain. There is nociceptive pain and neuropathic pain, right? One kind of being the direct trauma of like a cell or tissue, which is nociceptive, and neuropathic being the actual damage to the neurons that send these pain signals. These result in two different types of pain, right? Can anyone give me an answer as to what type of pain stubbing your toe is? Which I'm sure everyone's done at some point in their life. Is it nociceptive or neuropathic? Perfect. Excellent. Great. And how about cutting your hand? Is that any different? Nociceptive or neuropathic? Perfect. All right. So I'm going to skip this middle one for now. This one's popping up. We'll just leave that. Don't know how to do that. Okay. How about a phantom limb? Is that nociceptive or neuropathic? Very nice. Perfect. Right. So phantom limb. And we'll just go for, I'm sure you guys will even give a pretty good guess that trigeminal neuralgia is also neuropathic. And that's issues with the neuron. And the kind of tricky one would be pleuritic pain. So pleuritic pain is when you have pain when you breathe in. I'm sure a few of us, I definitely have had it at some point. Is that going to be nociceptive or neuropathic? Ooh, tricky one. Okay. That's correct. Yeah, it's nociceptive because it's normally due to inflammation of, say, something in your abdomen, and that will normally affect either the pleura around your lungs or possibly some of the nerves that are linked to those areas. So it's nociceptive in that sense. It's not a direct damage of the neurons that are kind of giving that pain signal, right? So like I said, nociceptive pain is your acute pain. That's normally stabbing or sharp, right? You can think of it as like someone, literally stabbing you with a knife, that kind of pain. I mean, as I mentioned, normally due to physical trauma or cell damage, right? And the mechanism behind it would be an actual injury that then activates free nerve endings, right? These are the nerve endings that are available that are specifically there for pain, which results in the release of substance that is sent to the thalamus and then goes to the periaqueductal gray region, which is your main kind of pain center in your brain, and that gives you the perception of pain, right? And in response, then your brain then sends signals down towards where the local damage is, and that results in the release of histamine. Is that pretty straightforward for you guys? So any questions so far? So this is probably the pain that most of us have experienced, common than neuropathic. So neuropathic pain is different. It's not acute, it's more chronic because you can't really solve the cause of it. And it's normally felt as a burning or shooting sensation, right? You might have heard of cauda equina, and that's normally compression of your lower lumbar nerves, and that causes a shooting sensation all the way from your knee down to your toes, along with a bunch of other stuff. But that's mainly a key question you kind of ask, like, does it shoot from your knee down to your toes or just to your knee? And it's due to the direct damage of the fibers that are related with pain. I have a diagram that's coming up later, and will cause typical symptoms of hyperalgesia. So this is like, it's super intense perception of pain for something that shouldn't be that painful. So someone like, touching you with maybe a thumbtack, and then it suddenly feels like someone's just torn off your arm, or allodynia, which is feeling pain when you shouldn't be feeling pain. So if someone shakes your hand, maybe taps you in the back, and you suddenly recoil because it's super painful. That's allodynia. So hyper being, an increased sense of sensation of pain for something that shouldn't be so painful, and allodynia is pain when there shouldn't be pain at all. So the overview here, it's a little bit kind of, I normally draw diagrams for this, but I'll just walk you through it. So we start with nociceptive pain here. There's cell damage, and there's a few things that get released. So there's activators, so there's serotonin, potassium, and bradykinin that kind of activate the pain centers, and the sensitizers, which are prostaglandins and leukotrienes right here, right? These are all pretty niche detail. So I wouldn't really worry yourself too much about these, but they basically then start the pain signal that goes down the primary neuron. And these will be either fast ones, myelinated fibers, which are A delta, sorry, or the slow C fibers, which are unmyelinated. So they don't have that wrapping around the neurons, which helps to fast track all the signals. These will go to the substantia gelatinosa in the spinal cord, and then send all the way up to the thalamus the pain signal via the secondary neuron, right? Primary and secondary basically mean first stop, second stop. Right, so first up to the spinal cord, second stop all the way up to the thalamus. And the thalamus is basically your rooting center, right? It sends signals to all different parts of your brain. So it sends it to the hypothalamus to kind of react, and again to this periaqueductal gray portion over here for your perception of pain, right? It's sent, something's gone wrong, it's gone up all the way up to the brain to tell your brain that something's gone wrong, and that's how you get the pain sensation. Now, for neuropathic pain, there's just damage to this secondary or possibly even the primary fibers, and this results in aberrant signals being sent to your brain. So most likely there are being pain signals being sent when there's no pain at all, right? And that's what you get with phantom limb or trigeminal neuralgia. So that's your neuropathic kind of mechanism. Now, I'm sure you guys have heard of the gate theory of pain, and there's two versions of this, right? There's the more likely that you guys will know, maybe have tried, is this mechanical side where the skin or rubbing your skin where something hurts will stimulate the alpha beta fibers, which are inhibitory to the pain signals that are moving up, right? And that, if you've ever knocked your hand on something, you kind of like rub it to make the pain kind of go away. And that's just simply how it works, right? The mechanoreceptors are stimulated, and then they activate the inhibitory beta fibers to stop that pain signal or reduce it. There's also the descending inhibition theory, which is basically your kind of like mind over matter approach, where the thalamus then releases serotonin and noradrenaline, and this also stimulates the A beta inhibitory neuron to kind of stop that pain signal going up. Any questions so far? All right, well, hopefully that all made sense. If not, hopefully that diagram will be useful, and these will be made available to you. Ooh. All right, so those are the types of pain. Now, in terms of managing the pain, there are three approaches, obviously. There's always a conservative approach, there's a pharmacological approach, and there's a surgical approach. So I've down here, there's three conservative approaches. Can anyone give guesses for what a conservative approach to pain management might be? Something that keeps you healthy. All right, this is a bit of a hard one. So I guess, basically what I have down here is conservative approaches. You can exercise to kind of improve your pain management. That's good. Your physiotherapy is also along that line, right? Just basically strengthening the muscles that might be the cause of your pain, or even just providing endorphins, right? There's acupuncture that's available, and there's this thing called TENS, which stands for transcutaneous electrical stimulation. Basically, how that works is it's basically activation of the alpha beta, the A beta fibers, which in the previous diagram were shown as to be the inhibitory signals. So there's the three main ways. For surgical, you can obviously do a nerve block, which you'll probably see in your second year, which is just kind of like local anesthesia of maybe the brachial plexus or trunk or division of the brachial plexus. There's nerve ablation, and there's also implants, which also help. So those are kind of the other ones, but I think the main one thing to focus on would be pharmacological management. So does anyone recognize this ladder right here? Hopefully that's a yes. This is just your typical WHO pain ladder, right? Great, thanks, Katie. So what we have here is basically a stepwise guidance to pain itself and how to manage it. So bottom here being pain-free, the first intervention you have is just a non-opioid intervention, right? So you start with NSAIDs or paracetamol, or possibly add an adjunct, which is caffeine. Next, if that doesn't work, you step it up to a weak opioid. So you start with codeine, dihydrocodeine, or paracetamol. Cocodamol, which is codeine and paracetamol. So you're trying to then delve into opioids, but you're still only the weak side. And they're really experiencing severe pain, and none of the previous managements have helped. You move on to strong opioids. So I'm sure you've heard of them: fentanyl, alpha-fentanyl, morphine, and similar kind of strong opioids, right? And this is just this whole stepwise guidance is basically to minimize the use of opioids for pain, because they can be really reliant, or patients can become very reliant, and kind of reduce the effect of the whole opioid crisis available. So with nociceptive pain, specifically, use different medications for each. So nociceptive pain, you have NSAIDs and opioids, right? So we'll just go through what NSAIDs are available. So this is, again, pretty big diagram, but I'll just talk you through it. So NSAIDs are basically, generally, they just inhibit the COX enzyme, right? There's 3 different COX enzymes, but mainly they just generally hit all of them, unless there's specific ones later. And so how COX works is basically it transforms arachidonic acid into prostaglandins and thromboxane A2, which is for clotting. But the main thing for pain is prostaglandins right here, right? And by basically inhibiting COX, you're stopping that whole pain mechanism occurring, reducing that pain experience, I guess. This obviously is used, since aspirin affects thromboxane A2, is also used for blood thinning, but it's only kind of a side note you got to make sure, because this is more linked in terms of the side effects of NSAIDs, right? When you prescribe NSAIDs, you always have to be aware of the patient's like bleeding history, if they have a history of GI ulcers or anything, because it does reduce the clotting ability of the patient, and therefore you can lead to GI bleeds in a patient if they have a history of it. There's also a risk of nausea and vomiting and heartburn with NSAIDs as well, because they also affect the dilation of blood vessels in your body. I'm sure if you guys have heard the triple whammy for kidney stuff, which is NSAIDs, ACE inhibitors, and ARBs, I believe. Yeah, ACE inhibitors, ARBs, NSAIDs, and thiazide diuretics, I believe. So they basically all constrict, sorry, afferent, so incoming renal artery, and therefore reduce the blood flow to the kidneys. And then the ACE inhibitors will dilate the efferent, so the ones going away from the kidneys. So you're basically reducing the blood flow to it and increasing the blood flow out. So that reduces the EGFR, because it messes with the pressure, essentially. I'm sure you've heard that before, I think in one of your first CBL sessions. Anyway, I'm going away from the... Who hasn't? Okay. All right. Let me just try and stop sharing it and then share it again. Can you see the PowerPoint again? Awesome. All right. So what I was basically getting up to was the effect of NSAIDs and what you have to be worried about them. How I remember NSAIDs is basically this acronym here, D-pain. So you can remember it stops the pain. So there's diclofenac, paracetamol, which I'm sure you've all heard of, and aspirin, ibuprofen, which is the main one, and naproxen as well down here. What we have over here on the side are basically COX-2 selective NSAIDs. So this celecoxib and etoricoxib. How I try and remember this is just a celebrity story, right? Celebrity story. And they're more beneficial in the way that they reduce the GI symptoms, side effects, sorry, but they increase the risk of thrombosis. Now, what you've got to be worried about with NSAIDs is if there is a overdose of NSAIDs, and that has resulted in something called salicylism, because there's salicylic acid in some of these. But basically, it's kind of body-wide kind of neuro response to it. So you'll have changes in hearing and tinnitus, respiratory arrest, and alkalosis, because interestingly, the NSAIDs kind of trigger the respiratory centers and cause you to hyperventilate. As you hyperventilate, you're pushing out all the CO2 in your body. That leads to alkalosis, right? Because higher CO2 is normally acidosis. It can cause seizures, nauseas, tachycardia, confusion, and dizziness. So it's pretty much, it hits all around your whole body for neuro stuff. But if you kind of see a few of these in combination and someone's been known to be on NSAIDs and possibly has a risk of overdose, that's something to definitely look out for because it's an emergency. Now, apart from NSAIDs, then we can, if NSAIDs don't work, we can kind of go up to opioids, right? And opioids just work on the opioid receptors in your body, and these are opioid receptors 1 to 4. And you can see here, opioids work on the opioid receptor, which stop cyclic AMP, which is CAMP, from working. And this basically stops them from opening the voltage-gated calcium channels for calcium to come in, and then basically transmit that pain signal, right? So it basically stops the transmission of the pain signal as it occurs. That's how they work, basically. I'm sure you've heard of the side effects, right? The main ones being, I kind of remember them with the acronym CRAP. So C as in confusion or constipation, R as in respiratory depression, A, you can either remember as anaphylaxis, possibly, and P being pupil, so pupils being constricted, which is meiosis, so pinpoint pupils. And if you see that, all those kind of 3 or 4 symptoms in a patient that is kind of not really responding very well, it's highly likely that they've had an opioid overdose. So what can we do in this case? With overdose, the response would be, I remember Pete Tong, you know, if you go to a rave and Pete Tong's playing, there might be drugs involved, and therefore you can link that to opioids. So Tong is basically your response to it. You have to give a patient thiamine, oxygen, naloxone, which is a reversal of opioids, and glucose to kind of stabilize the kind of the neuron side to it. And so naloxone you have here is your fast acting, while naltrexone is a kind of a longer acting for 10 hours. That's kind of your response to opioid overdose. If someone's addicted to opioids, there are also different methods. So there's methadone and buprenorphine, which is a partial agonist. And these kind of, they provide the opioid kind of response or stimulation in your body, but at a lower rate for both of them. So it's not as addictive, while something like heroin is very fast and heavy hitting. So you get that real rise, which is more addictive than any of these kind of partial agonists. Right. In search of time, you guys, I'll give you the link to this so you can search it, but I've included some information for agonists, partial agonists, and antagonists, but we've covered them here. The agonists being morphine, dimorphine, fentanyl, partial agonists being what you'd use for addiction, which is methadone and buprenorphine, and reversal over here for the antagonists. Why do we give thiamine? So thiamine is generally just vitamin B1. It's mainly basically used to, I think, stabilize the brain kind of in response to the opioids in the same way that glucose is used. But I'll definitely look that up to make sure because it's kind of like maybe I'm 70% sure that's the case. But it does fit nicely into the acronym. Yeah. Ooh, that skipped more than I thought. So, as you've seen there, there's also neuropathic pain, right? So neuropathic pain, because it's different from, in terms of mechanism, from nociceptive pain, you have to approach it differently. And you mainly just use pharmacological approaches. Particularly you use like anti-epileptics, which are calcium channel blockers. So what you have up here is pregabalin and gabapentin, which can be grouped together because they basically affect the GABA output or circuit in your brain. Pregabalin affects the transport of GABA, which is GABA is an inhibitory kind of neurochemical, and gabapentin affects the synthesis of GABA. So that's how they're slightly different, but they're both used in the same way. You can also use carbamazepine, which is again an anti-epileptic, specifically for trigeminal neuralgia, I believe. And apart from these calcium channel blockers, you have the TCAs, which are the tricyclic antidepressants, which was mentioned before by Kat. These are the triptyline, so it's amitriptyline or nortriptyline. I think the extent to which you have to know them is basically know that these drugs are available for treatment for neuropathic pain. Just maybe understand the mechanism of action. But beyond that, I don't think you really have to understand too much. Because I know drugs, at least for me, when I was in year one, were really just alien language. That was quite a lot so far. Do you guys have any questions? Want me to slow down? Want me to go over anything again? I'm definitely not doing. Sorry. Yeah. I'll take that as a no. But so the next thing I was going to move on to was referred pain, which I'm sure you guys have heard a lot. But I'll just try to work through it in a simple way that I understand it to be. Right. So referred pain is basically where your brain gets mixed up with where the pain is coming from. And this basically occurs because parts of the skin and your viscera, which is like your internal organs, they synapse on the same part and travel up the same route to your brain in terms of pain. So if, say, something in your heart, if you get a heart attack, you get the typical left side pain down your arm and into your jaw. That's because the same nerves that innervate the heart and your left arm and your jaw, they both kind of synapse in the same region in the spinal cord. So because it's more likely that there's injury to your skin than to your internal organs, your brain sometimes mixes up the pain signals as coming from that region in the skin rather than your actual heart hurting. That's simply that. Your brain's mixed up where the pain signals are coming from and therefore tell you that it's coming from some part in your skin when it's actually part of your internal organs. This diagram here is just to help you kind of understand which regions would hurt depending on which organs. I would highly advise you not to memorize it completely unless you have a lot of time. I think the main ones to remember are your heart being for your arm and your jaw. Nice, that's great. And that's T1 to 5. Anything for your kidneys is obviously your loin to groin, kidney stone kind of pain. That's T10 to L1. And for your diaphragm, which sometimes might be affected by, hepatitis, your liver inflammation or gallbladder inflammation, that's C3 to 5. And it is referred to your shoulder, so your right shoulder. So sometimes when you have inflammation in your gallbladder, patients complain of right shoulder pain because that's, inflammation of your gallbladder, which affects then your diaphragm, which then sends up signals, which are misinterpreted as being pain in your shoulder. Thanks, Owa, for that. That definitely looks like a lot better drawing out of kind of nephrotoxic drugs for the triple whammy that I mentioned. That's great.